Hello there, this is Kamran Popal back again with another emergency scenario. This is also a prioritization scenario, and the question is, you're the on-call reg at 11:30 a.m. So this is the morning time, so important to mention. The SHO calls with a number of patients. The first patient is a 38-year-old gentleman who's got 9 hours of sustained painful erection, so priapism scenario. 50-year-old suspected sepsis post cystoscopy and biopsy, and you get a call whilst you're going towards A&E about a 40-year-old who was having a hysterectomy and has sustained a ureteric injury. So over here they've not asked for, but you have to keep in mind how you would prioritize this. I mean, if you've got a CT and an F1 and a consultant, this is daytime. So priapism is something that I would see. So registrar, because this is a specific urological skill, and obviously you all know, and we'll come to the specificity of the priapism scenario. Sepsis post-biopsy, any CT should be able to deal with initial CRISP protocol, core training, and hysterectomy is a consultant job. So, you can prioritize it accordingly, and you can make this one line, which I use with every prioritization scenario, So I've used and answered it multiple times in the past, so you can see my previous videos how I answer for my team and myself and how I would prioritize them safely. The question is assessment of 50-year-old with suspected sepsis. So how will you assess this 50-year-old? So I will assess the patient according to the CRISP A to E protocol and concomitantly looking at the operation notes for any complications and the indication of the procedure. I will also look if there is a history of urinary tract infections and previous cultures available on the system, and if any blood results or blood gases are available from the accident emergency department today. I will initiate the sepsis 6 protocol immediately if during my A to E assessment I find any signs of sepsis. My assessment will include A, or airway checking for if the patient is speaking, B, examine and auscultate the chest, check SpO2 and respiratory rate and give 15 liters of oxygen via non-rebreathable mask. C would include assessing heart sounds, capillary refill time, peripheral warmth, blood pressure, heart rate, and obtain an ECG. I will also put I would also give IV fluids and antibiotics as indicated, also do full blood count, use any CRP, clotting, group and save, and a blood class to look at the lactate and metabolic status. Then D, I would look for neurological status, GCS, and the patient's BM, and E or exposure, I would check for temperature, examine the abdomen for flank pain, peritonitis, propubic pain, palpable bladder, and catheterize if needed. I would then escalate to the ITU or the critical care outreach team if not responding to therapy and resuscitation. So this is how I've structured the answer. Again, this is a very concentrated answer where you've got an initial line that I say, then I say CRISP, then I say sepsis, then I say my assessment, and then I say my escalation. But if you're structured, you will not miss it. So if you've written the answer down, you've got these things in your mind, then you can, tick every box on the examiner's sheet. Next question, the patient has got a temp, so this is I think the same question going on. So temperature is 39.4, heart rate is 112, saturation is a 96 on room air, blood pressure is 65/40, and the patient is flushed. A biopsy was done 2 days ago for a red patch within the bladder. How would you proceed? So, I mean, I've already said sepsis 6, actually, or mentioned it briefly, but I've not really said what I would do in that sepsis 6. And over here, you can say sepsis 6 and all the things that come in there, and also the CCOT and ITU review, and then consider some imaging, which is CT urogram with excretory phase plus CT cystogram. I mean, this is more just the reason I've written this is because, in a biopsy, they didn't mention where the biopsy was taken from, was it close to the UO, whether there's a ureteric injury, and whether there's a bladder injury, so CT cystogram can be done, whilst the patient is within the resus department. You can't really essentially do a catheter cystogram straight away, or you can actually. If you've put a catheter in, you can do a CT cystogram as well, but if you're doing a urogram, you might as well do a cystogram at the same time. But yeah, so that was my answer, and that is what I wrote in my notebook. So the patient's been given 2 liters of fluids, blood pressure still 80/40, non-responsive. What are your next steps? Again, inform on-call consultant, ICU and H2 escalation, and inform the family. So family is important, so remember that. You get a call from Gynae Theatres, the consultant has not arrived. What are your next steps? So call the on-call consultant again. If that doesn't work, then call another consultant available or the clinical lead urologist in the hospital. And thirdly, a senior registrar or associate specialist competent at dealing with ureteric injuries if available. Because this is 11:30 a.m. during the daytime, you might be able to find someone who can help you with this. Right, so moving on, the SHO contacts regarding the... Sorry, question before that. So you've got a call from Gynae Theatres, the consultant has not arrived. What will you do and what are you... Sorry, we have answered this question. Okay, so the SHO contacts you with the priapism in A&E. The patient has had morphine, the patient is still in pain, and SHO hasn't managed priapism before. What are your next steps? That is why, I said, say priapism is your job, not the CT's job. Even though, it might be difficult. As far as you can justify them, it's fine. There's no right or wrong answer, but it makes your life much easier if you say that you'll see the priapism and ask the SHO to see the cystoscopy, because essentially, he should be able to initially resuscitate the patient. But priapism, the patient's stable, but the patient's got priapism, and the SHO's got no idea how to deal with it. So it's better if you deal with it. So what are your next steps? So I will go and see the patient straight away, take a brief history and perform a clinical examination after I've offered him some analgesia. My history will aim to identify etiological cause and subtype of priapism. First, we will try to define priapism, which is whether this was persistent, unwanted, and greater than 4 hours in the absence of sexual stimulus, what was the onset and duration of the priapism and the severity of pain, and any previous episodes and what management was given previously. I would rule out risk factors including sickle cell disease, hematological or pelvic malignancy, trauma, antipsychotics, illicit drug use, erectile dysfunction drugs such as PDE5 inhibitors, intracavernous or urethral prostaglandin E1 use, and I will ask for other medications such as anticoagulants and allergies and when he had his last meal. So this is how I put my history down, a quick history, and then I would then perform an examination in the presence of a chaperone, ideally in a side room, because it's not nice if he's in a bay or doesn't have a curtain around. It's preferable he's in a side room, ideally in a side room. Do a general examination of blood pressure and pulse or evidence of trauma, specific examination including abdominal palpation for palpable masses or organomegaly including malignancy, the penis feeling for a rigid, tender corpora with a soft glands indicating low flow priapism, and a DRE feeling for any pelvic masses. Then they can ask what are the types of priapism that you know about. So you've got low flow or ischemic priapism or high flow or non-ischemic priapism, and then you also have a stuttering priapism. Then there's a question, the patient's got 8 hours painful erection following cocaine use, what type of priapism and why? So the painful history suggests low flow. What test will you do to confirm this? So a blood gas analysis from the corpora, and the gas shows acidosis, reduced glucose, reduced PO2 and increased PCO2. What is your diagnosis? Diagnosis low flow or ischemic priapism. So if they ask you about management of priapism, then you would say, I would start off by informing my consultant and then I will do a penile block. I would use a green butterfly needle and insert it into the corpora via the glands and aspirate up to 100 ml of blood up till all the clots have been removed. Washout can be considered, but not always needed. I would then use 200 to 250 microgram shots of phenylephrine under cardiac monitoring. I would inject these 200 to 250 microgram shots every 10 to 15 minutes with a maximum dose of 1 milligram per hour. I would then, if the priapism does not go down with the phenylephrine, aspiration and phenylephrine, then we can refer this patient onto an andrological center for consideration of winter shunts or T-shunts, or unless there is an andrological service available, in which case I will speak to my consultant and go ahead with doing them in-house. So this is something that you should be able to mention. Sometimes they ask about how would you would prepare phenylephrine. Now everyone prepares it differently, and one of my very senior professors, Prof. Watkin, who's a big name in andrology, suggested that they come in 1 milligram 10 milligram per mil vials, and we should dilute them in 200 mils of normal saline. And when you do that, that is approximately 200 micrograms in 4 cc. So some books say 100 of saline, but it doesn't make much difference saying 100 of saline or 200. So 100 is sometimes easier to say, because 100, if you dilute 10 milligrams per mil into 99 mils of saline, making a total of 100 ml solution, that means that the 2 cc will be equivalent to 200 micrograms. So 2 cc is 200 microgram, and then so on and so forth. So it's easy calculation. But if you know what you're talking about, you can say either or. Also, Prof mentioned about putting the needle through the glands into the corpora rather than putting it between the 2 and 3 o'clock position, which is also mentioned in some areas in books, because a big hematoma forms on the side and it looks very ugly afterwards, and henceforth the glands automatically becomes a tamponading area for the corpora if you put it through there. And if this turns out to be needing a Winter shunt or a T shunt, you're going through the same holes anyway. So yeah, it's something to consider. This is something I learned because I've dealt with 2 priapisms in my career, and it's always good to have the guidance and the expertise of someone who deals with this every day or has dealt with thousands of these. Anyway, all the best. So this is the end of this prioritization scenario, and we'll see you next time with another prioritization scenario. Do have a look at my extra question videos at the very end, and I would be talking about some questions that I gathered again, and some might be repetitive, but those were some of the stations that I gathered from the interviews. Not the interviews, from the practice interview courses. So yeah, all the best, and I'll see you next time.